Hello everyone, this is Instructor Howard, and today I'm bringing you guys to work with me. I want you to get a glimpse of what it looks like or what it seems like to code in an outpatient setting. I work as an auditor, so I do both coding and I also review the charts that coders have coded to assure that they are compliant and that the coding is accurate. What you see in front of my screen right now is a coding compliance tool that I use to verify my coding against theirs. So as you can see, the screens are blank, and what I'm doing right now is I'm just working on a case. I am reviewing the documentation from the emergency department for a patient, and I am going to make notes on my notebook and go through the services that were rendered and the patient's diagnosis, and then from there I will code that, and then after I code it as an auditor I will verify what my coder has chosen to assure that we both come up with the same thing. Okay, so let's get started. So 90% of the charts that I code are saved inside of an EHR system. That is an electronic health record system, and what I can do from home or through any computer is to pull the patient's chart up based on the date of service, based on the medical record number, and based on the visit number. So right here I have a chart ID listed here, and what it's just giving me is this is the chart ID for this date of service, and the date of service here is August the 6th. So what I start doing when I initially began to code for the emergency department for this particular facility is I look at the services that were rendered initially, or the services that were ordered and done by the nursing department. That will give me an idea of whether or not we need to code for any procedures. This particular facility only wants us to code for any procedures done in the surgical range of our CPT manual and all diagnoses. And then there are times when we have to code for different things. For example, this particular group of charts we're coding is for the emergency department, but they also have groups of charts that are listed under same-day surgery, where the patient is outpatient, comes in for surgery, and then leaves. And then also we have some charts that are for radiology services only and laboratory services only. So this facility, this particular patient here, we're just coding for the emergency visit. So as you can see here, the patient was discharged, and let me get my my pen here. So the patient was discharged. Okay, and that's like the last thing that was done, and it's in reverse order. The patient was given a pain pill, some pain medication, and then the patient was given a urinalysis test for this date. So these are the things that I'm going to jot down in my notes. Urine test, pain medication. I don't need to put that the patient was discharged. We know that they come and leave on the same day, and we also know that this patient was discharged home, so they were not admitted. So that's something that I can just overlook at this time. Since all of my records are listed inside of a document filter, the only thing I would need to do is click on the link for the next document, which is the emergency physician documentation, and then it will take me to the other portion of the charts that I need to review. As you can see, there are several sections of an electronic health record. It's just like a patient chart, hard copy chart. The only thing is that for each visit, the patient has one seamless file for that particular visit only. So we're not going to find a whole bunch of information in here from a year ago. Those will be saved under a different chart number. Okay, so right here, and let me get my pen here. So right here, what we're seeing is, and let me make sure. All right, so right here we're seeing that we have the chief complaint, and these are some things that you will probably move this over. Let me erase that. Here's some things that you will probably have seen dealing with the evaluation and management type of coding. I'm trying to get my markers together. I'm sorry about that. So the chief complaint, and I document this in my note, is that the patient came in for vomiting. So this is considered a sign and symptom of another problem. What we need to do is determine why she's vomiting, and if the doctor can give a definite reason for her vomiting on that day, then the vomiting diagnosis may not need to be used, but we'll get to that a little bit later. Okay, so since this is a minor, the patient has her history that was obtained from her grandmother. So the other section of the chart is our history of present illness, or HPI. And so what I'm doing is I'm just reading in here to determine how severe this current illness is. So the child has vomiting since last night, a small amount this morning, no hematemesis, which means there's no blood in the vomit, no headache, no nausea, no diarrhea, no constipation, no cold, cough, or earache. So basically she's vomiting without any other symptoms. The patient is asymptomatic. So now we can get into past medical history. So I've documented vomiting under my little notes in my notebook for chief complaint. I'm going to go under past medical history. HPI was, I'm going to say NA, nothing else under there except for vomiting. I have a little note section for HPI. Similar to what you're looking at, I'm just abstracting the relevant information so that I can assure that I pull everything I need for coding. Okay, so we have our past medical history. The patient was born as a premature twin. Past medical history, I'm going to jot that down. Premature at birth, and also a twin. And then she has a gender identity disorder. That's another diagnosis. And I'm just going to jot this down. This may not be contributory towards our vomiting today. However, if we go a little further into the record and determine what the provider reviewed and any test that he's given that comes back positive, then we can probably include this diagnosis. Okay, so her past surgical history. She's had mouth surgery. And then family history is not significant, and her social history is that she lives home with her grandmother. If this was an adult patient, then we would, in social history, we would probably have to abstract whether or not they are a current smoker, because that's social history, and if they have used illicit drugs, or if they are they're using, or if they have abused alcohol. So that's what social history gives us. Family history is not significant. For example, if the mother or father has had cancer, breast cancer, cardiac problems, that's our family history. Surgical history sometimes is important, but it may not be in this visit. But providers generally take this every time in order to come up with the appropriate level of office visit for their E&M. For this facility, we're not going to code E&M. We're just going to be coding for the diagnosis and procedures, surgical procedures, if they were rendered. Okay, so the patient is allergic to Tylenol, and what they get is a rash when that happens. So that's something that we can document as our diagnosis, one of our diagnoses, or information is allergies. Okay, because that might be a reason she's vomiting. We don't know yet. Okay, so let's look at the triage. These are the vitals, which the nurse has done. The provider says, you know, they're normal. He didn't list what they are here because they're listed under documentation for the nurse in another spot of the chart. So he didn't need to duplicate them. So here's our physical examination, PE. General, he's going with general or constitutional, how they look, if they're nourished, distressed, do they have a fever, how's their breathing, any wheezing. And then he's looking at their skin. How does she look? Normal, no rash. And you have the eyes. Sometimes this section is listed under HEENT, head, ears, eyes, nose, and throat. But he separated them. He says the eyes have conjunctive, the conjunctiva are clear. And then the ear, nose, mouth, and throat, he gave a detailed examination, and here are the details about that. Normal mouth and gums, mucous membranes are moist, tympanic membranes are clear bilaterally, the throat is clear, and then again he listed mucous membranes are moist. He duplicated that, probably because he didn't remember that he typed it. Okay, the head and neck, detailed exam. Head details, normal cephalic, atraumatic. Neck details are supple, which is another term for normal. And then the head and neck comments, no meningeal signs, which means no meningococcal, signs of meningococcal virus or meningitis. And so now he's going into a full detailed exam about the respiratory and throat. And he's given us the details. They're clear. Breath sounds are equal. Good air movement. The chest details. No retractions. No tenderness. Cardiovascular. Regular rate and rhythm. No heart murmur. The pulse is normal. And then we're going to do the extremities. Everything is normal. Gastrointestinal, which is her stomach. Normal. And then he's going to give us, well, here's the details. No guarding, no rebound, normal bowel sounds, no CVA, no tenderness. And then we're going to go into neurological. Neurological means how alert are they? Usually alert times 3 means that if they can see, if they can speak, and if they can hear. That's what alert times 3 means. Non-focal examination with symmetry, strength, and the lymphatic system, which are the glands, the neck, and the armpits. No lymphadenopathy, which means that there's no swelling. So we're going to look at what he ordered a urinalysis. That's one of the tests that we saw under the other portion of the chart. And the results are here. So what he's seeing is a trace of leukocytes. So one of the rules about coding in an outpatient setting is that even though the results are listed, the provider must interpret them, and he must document his interpretation in order for it to be a viable diagnosis for coding for the coder. That's just a sidebar note. So we're going to go into assessment and plan, which is what he does after his examination. He's saying he'll give the patient some Zofran and by mouth, and he'll check the urinalysis test. So he's coming back for the repeat exam. He's giving us the date and time at 11:06, and that sometimes matter depending on what was done prior. If anything changes in the next examination, you know that like these particular results were before that. Okay, so here he's reviewing, well, under his repeat examination, he has done a review of the urinalysis, and he's showing that there is trace esterase and no ketones, and he's discussed the findings with the grandmother under re-examination. Patient is feeling better, tolerating fluids, no nausea, no vomiting, abdominal pain, and everything is stable. So he's given her a final diagnosis of vomiting because he cannot find a reason, a distinct diagnosis and a reason behind her vomiting in this case. So what I'm picking up here is the final diagnosis of vomiting, and her allergies will actually, there's a diagnosis for allergies in the ICD-10 manual. Her examination, everything is clear, so I'm documenting that. And then as far as her test, the urine is positive esterase. So what I would expect my coder to code is you know, the vomiting, because that's going to be the principal diagnosis. That's the main reason the patient was seen. There's no other reason that the doctor can find besides the fact that she's just vomiting. So that's going to be listed first. It should be. And then her abnormal urine test could be listed second, because that's something that was discovered in the examination. And then her allergies. So I'm going to verify that, and then I will document my information in my other software system. So I'm reviewing what my coder coded. He did the principal diagnosis here of vomiting. He's also given the diagnosis of allergy, and he's saying that the patient is on long-term use of non-steroidal agents, NSAIDs. We are going to have to verify that because I did not see that in the chart. So I'm going to look under the nursing documentation because it wasn't under history. And I'm also going to verify if the person is taking any other medications besides what's been described or prescribed today. So what I need to do first and foremost is I need to come up with a diagnosis for the patient's abnormal urine test. And this software is called 3M. This is an actual encoder. It is an electronic version of the ICD-9 manuals, the CPT books, and the coding rules and guidelines all in one system, which is very easy for us as coders. Sometimes we have to, you know, for myself, sometimes I have to go back to the actual manual and do the coding old school because I'm used to coding it in that manner. But if I'm just looking for something simple such as abnormal urine test or abnormal test, then I can actually look this up under here, and it's just a search. It's just a search. Let me see. Urine. And we can spell. He says esterase. Nope, electrolyte level. Let me verify what he says is positive. Leukocytes. White blood cells. Nope. Let me go back. So this is one of the reasons why it's not really good to use this, because you have to kind of type your coding, type your wording in and search for it. Function study. Let me go. Urine, fluid or body substance. It will be much easier for me to do this it will be much easier for me to do this with the manual. So abnormalities, let me spell urine. Okay, and then let me spell, see if leukocytes come up. Leukocytes does not. White blood does not. Okay, let me go back. And other specified or other abnormal urine. I'm going to see. So that's not coming up. Electrolytes again. Okay, so what I'm going to do is I am just going to try one more thing. Okay, leukocytes. Leukocytosis. Nope, that's the wrong thing. Alright, so then I'm just going to go to other specified. Do not wish to code. There. So with this particular software, it's a search mechanism, and as you can see, it was hard coming up with leukocytes because that's what the test says, abnormal leukocytes in the urine. And let me document those findings because that should have been reported. R8299. Okay. And this is also just a sign and symptom of another issue. Excuse me. Most sign and symptom codes begin with an R, just so you know. And back and cancel. And I'm actually going to just document that in my findings. I'm not going to add the coding in the system for the patient. I will send my coder a report just to let him know what I've come up with and what's missing. And then I'm going to also verify that the patient is on NSAID anti-inflammatories because I didn't see that with the HPI and the medical history. And if that's not documented, I will have the coder delete those two codes, and I will definitely have him add the abnormal leukocytes. And that's pretty much it. That's pretty much what I do on a daily basis for this particular facility. I will attempt to make more recordings to show you guys what I will do for other facilities dealing with a different EMR system, EHR system, and also a different chart type. So you can see that the documentation is pretty much the same, but it's in possibly a different format depending on the system that we use. And that's it. Thank you for watching. Have a great day.